good morning.
You gonna see it sometime right now on this one.
Okay, we're recording this. All right. So, good morning. My name is Miss Harris. Uh, I am a family nurse practitioner. I've been practicing nursing for over 23 some years. Um, with Elimination, I teach assessment and I teach perioperative care. I don't know. That's about it. Um, Today we're going to be going over elimination. I don't know, we probably will use all of the time. I have a few videos um, that are, embedded on the PowerPoint on Canvas that y'all can watch. If we have time, we'll watch it here. Because it really kind of summarizes everything that I'm going to say. Elimination is you're going to hear the same thing over and over and over again. So it's kind of redundant, but it's redundant for a reason. And then we're going to follow up with BPH. That's going to be the second. So we're going to be dealing with diverticulitis, diverticulosis, and BPH. And that's going to be our exemplars underneath the concept of elimination. So to kind of start off, elimination is the excretion of waste products from the kidneys and the intestines. So the bowel's ability to expel feces with adequate hydration or adequate intake, and the bladder's ability to void must be in place for normal elimination to occur. So with bowel elimination, it's the formation, the passage, and the excretion of waste products preceded by the urge to defecate at routine. For bladder elimination, it's the voluntary control or passage of greater than 30 to 50 cc's of urine an hour. So 8-hour shift, how much urine should you have minimum? 240. All right, so today we're going to, like I said, deal with the exemplars of diverticulosis, diverticulitis, and BPH. So, all right, so this is a picture of the colon, most likely the sigmoid colon. That's where the majority of diverticulosis and diverticulitis can occur. These are diverticulum. Each one diverticulum, multiple is diverticulum. This happens because of pressure in the colon. Why do you think there would be, what can cause pressure in the colon? Straining because of what? Constipation. 95% of our lecture today. All right. So the pressure in the colon will cause areas that are weakened to herniate, causing these diverticula to develop. So diverticulitis, y'all will probably see it sometime in your nursing career. It affects millions of patients. There are millions of hospital days. So with that, it's just basically saying that you're going to come in contact with somebody who either has diverticulitis, has a history of diverticulitis, or has a history of diverticulosis. Like I said, a diverticulum is a herniation or an outpouching or weakening of the bowel mucosa caused by increased pressure within the colon and weakening the wall. Diverticulosis is a condition of multiple diverticula without disease. No inflammation, no infection. Diverticulosis. Inflammation, infection, diverticulitis. Many people may have diverticulitis and don't even know it. It's something that occurs gradually as we age. So sometimes you will see a person probably in their 50s. I'm going to say 50 is not a magic number, but it's just to say that as people get older and years of constipation, these diverticulum or diverticula can develop. Um, Inflammation of the diverticula, that's when those outpouchings in that intestinal wall become, the inflammation because it becomes infected. And the majority, like I said, will occur in the sigmoid colon, 90 to 95%. And like I said, it increases with age, starting at about 60. And it's caused by that increased pressure in that intestinal lumen, causing the herniation because of those weakening areas or the defects in the intestinal wall. And it's caused by, we talked about constipation. So what causes constipation? Constipation is the consumption of a low carb diet, inadequate hydration, obesity, because constipation, low fiber diet, poor eating habits, that would kind of go along with obesity when we talk about the poor diet. So all of these things will cause the development of the diverticulosis that can potentially turn into diverticulitis. Just because someone has diverticulosis does not mean they're going to automatically develop diverticulitis, but of course, if it's there is a possibility. So diverticulitis kind of, it's caused when food or bacteria becomes trapped in those outpouches. So think about it. You have all of this waste product. The waste is supposed to get on out your body, but because of the constipation, it's just sitting there. And so bacteria is forming, and that bacteria gets trapped in those diverticulum and can cause diverticulitis. The bacteria can also cause abscesses in those outpouchings, and those abscesses can perforate. So if it perforates, where do you think all of this waste is going? Into the peritoneal space. So you have all of this stuff that's supposed to be contained in the colon spewing out all inside your intestinal space. So, and I'm going to get to this coming. Pain when somebody comes in is in the left lower quadrant. Okay, that's where they may come in fetal position, they may come in as hurting. We're going to talk about how the pain can be from mild to severe. But with perforation, you'll find that now the pain is generalized. It's generalized because the infection is spread all into the intestinal cavity. All right, so that's like automatically going to surgery. So you can see chronic constipation, like that. Precedes the development of diverticulosis by many years, increases the pressure in the bowel wall, leading to the development of diverticula. We talked about the decrease of dietary fiber. We talked about how it mostly occurs in the sigmoid colon. Keep it moving. So, as a nurse, person comes in, what are you going to see? You're going to see they're going to be complaining of pain, usually in that left lower quadrant. They may say, I haven't been able to eat. They'll have a decreased appetite. They may come in with fever. Fever may be, maybe like 1 or 1.5 or somewhere around there. They may say that the severity is, mild to severe. So let's just say 5 to 7, somewhere around there on their pain scale. They may complain of cramping. And then, like we talked about, If perforation has occurred, that pain will switch from that left lower quadrant to be more generalized in the abdominal cavity. A person may also, when you're asking and you're gathering the information and the data from them with your assessment, you're going to say, well, have you been suffering with any kind of constipation? And the person may say, well, yeah, I've been having some constipation, but now, I'm just having diarrhea. Okay, so you're looking at that constipation, because what happens? You're constipated, you're still eating and drinking, so now all of the liquid stool is going around, and so now you're having all of this diarrhea. Okay, so they may complain, they may say, I've been having some constipation and diarrhea. We talked about the pain to that left lower quadrant. They may even complain about some bleeding. They may, say, I don't know, when I wipe, I notice some blood, or so what we'll probably do, they'll probably say, well, why don't you get a hemocoat of the stool and see if there's any blood in it. Let's see. As the condition worsens, the patient, we talked about fever, they'll have some fatigue and weakness. They may have anemia because over time, if somebody's just slowly seeping, blood in their stool, if you work in the ER, it's not uncommon where an old elderly person will come in and they'll say, I'm just not feeling good, and we draw labs and their H&H is like, I don't know, 5 and 12 or something like that. And you're like, wait, how are you walking? How are you standing? But it was a slow, seepage of blood over time. And that would be with a person who probably had more of diverticulosis than the diverticulitis. The diverticulitis is going to definitely bring you to the hospital. They may even have some guarding. You go to do your assessment, they're like, oh, don't touch there. So that's possible. That's also an indication of something is going on in that abdominal area. And like I said, if the diverticula ruptures because of an abscess, we're thinking peritonitis. The vowel sounds will change. They will go from, maybe normal to now they're going to hypoactive, because now you had all of, you had that peristalsis, you had all of the stool and it was moving and stuff, but now it's going into the peritoneal space, so you won't hear it as well because now it's everywhere. All of that stool that would be rumbling is just going right on out. So the vowel sounds will decrease. So that'll be another indication of change. Alrighty, so this kind of sums it up. So where's the pain? Left lower quadrant. How does it feel? Tender, crampy. What aggravated it? Chronic constipation, low fiber diet. So how do you fix diverticulosis or prevent it from continuing to occur? Prevent constipation. The timing is, the onset is gradual. The pain comes and goes. They may rate it a 5 out of 7. They may complain of some rectal bleeding, straining, constipation, diarrhea. When you're drawing labs, elevated white blood cell count, letting you know that there's some kind of infectious process going on. The sedimentation rate, that's an inflammatory marker that they use. More or less, you really look at the white blood cell count, because if you have gout, your sed rate will be high. If you have osteoarthritis, your sed rate is going to be high. So, but you may see it, and just to know that that's an inflammatory marker. They may have an elevated temp, elevated pulse, pain, fever, tachycardia, and they may have some pus, some mucus, some blood in the stool, and of course, somebody's bleeding from their rectum. The first thing they're going to think of is, I have cancer. Usually that's where everybody goes, like everything. I got cancer. So, You can't really say, oh no, Mr. Smith, you have diverticulitis. You just say, well, let's just wait till all of the imaging and all the tests come back, and then we'll know for sure. We try to relieve some of their anxiety. All right. So what else do we get? Okay. So more information. They may complain of, you're going to see fever. They may complain of chills. You may see tachycardia with the vital signs. We talked about that generalized abdominal pain that will occur, especially with perforation of the diverticula, and the onset of peritonitis with that perforation. Okay, so with diverticular disease, if they're just looking at diverticulosis, you would get a variant minimal. That's like kind of their gold star. You may see a colonoscopy or a sigmoidoscopy to kind of confirm diverticulosis. But if you're thinking, or if they're not thinking, you may have a resident that's not really quite sure what's going on, and they put on their barium minima, and you're saying, okay, this person has fever, chills, burning, they have all of these symptoms. I think there's an infectious process going on. You have to say, wait, are you sure you want to give this barium minima? Because what do you think a barium minima is going to do to the colon? In what kind of way? But why? Okay, but why would it get, okay, so you're saying pouches, but say something before that. How do the pouches develop?
The pressure.
Pressure. All right, so what's going to happen is that for a barium enema, the pressure of the enema is going to, the amount of fluid for the enema is going to increase the pressure of the intestines and possibly make that diverticulitis now perforate. So even though it's a diagnostic tool, but it's only for diverticular disease, meaning the diverticulosis. If we're thinking, to go back, the reason why you wouldn't, if you also saw an order for a colonoscopy or a sigmoidoscopy, you would question that as well for a person for diverticulitis because, think about it, they're taking a tool, they're inserting it into the rectum, and they're going through. That increases the chances of perforating a diverticulum that may have an abscess. So you would question those orders. Alrighty. So with that, the real thing is you're going to see a lot of this CAT to diagnose diverticulitis. Let's see. All right, so therapeutic management. All right, so you're working in the ER, person comes in, left lower quadrant pain, fever, chills, all of this stuff. What do you think the first thing you're going to do? Well, okay. Skip the assessment. What intervention you're going to do? And what you going to do with that? You're going to put them on NPO. All right. You're going to put them on NPO. And so after you put them on NPO, what's the next intervention you think you're going to do? So they're just coming into the ER. You say, okay, Mr. Smith, can't drink no more drinks. What's the next thing you're going to do? No. How? IV. Next intervention you're going to put in is an IV. With that IV, you're going to also draw your lab work that's going to show you your white blood cell count, your H&H, things of that nature. Y'all know this stuff. Y'all know. All right, so make them NPO. put an IV. The IV is gonna allow them to get fluids. All right, you're gonna get your fluids and antibiotics and pain medicine because they're gonna be in pain. Then, if a person comes in and they're nauseated and vomiting all over the place, what do you think you're gonna put in? NG tube. You're gonna put an NG tube in them. That's gonna also empty all the contents out of your stomach to stop all of this retching. Because think about it, vomiting is going to increase the pressure as well. So, and then that's also going to allow the bowel to rest. So you're looking at NPO, IV, NG tube if they're nauseated, vomiting. Okay, so let's just say person diverticulitis has gotten better, no perforation, antibiotics, stuff, stay in the hospital, they're good. So when we're talking about discharge teaching, because when you start, as soon as a person is, so you're on the floor now. So as soon as a person come in and they're admitted, you're thinking of discharge. So you're thinking of, okay, what kind of discharge teaching that I'm going to give them. You're going to talk about preventing constipation, and you're going to tell them what kind of foods to eat. So what do you think that you would teach a person to say, hey, these are the things that you have to do to reduce the incidence of diverticulosis and to possibly prevent diverticulitis from occurring again? High fluids. So you're going to give them fluids unless it's contraindicated. So if somebody has CHF, you're not going to be saying, oh, drink as much as you want. But you're going to tell them about increasing fluids, maybe 6 to 8 glasses a day. You're going to tell them to eat bran. But watch out for the bran. Tell them, hey, if you can start slow because bran can cause a lot of gas, which can cause a lot of abdominal distension. And they've been hurting, so it'll cause some discomfort. Tell them to do that slowly. Tell them to eat, what is it? Greens, salads, fruits, spinach, all of these things. What are you going to tell them to avoid, you think? Seeds, because that can get what? Get trapped in those diverticulum, yes. So we're looking at, I don't know, strawberries, raspberries. We used to tell people don't eat popcorn because of that husker, that yellow thing that could possibly get trapped. We just used to say it. Nobody told, just something that we just always used to say. But anything that we think that can get caught in that's not technically digested can get caught up in those diverticulitis. Let's see. Of course, you want to tell a person, Mr. Jones, what kind of activity were you doing? Oh, well, I just didn't watch TV all day. Okay, can you get outside and start exercising? Exercising, can help increase, abdominal, musculature and increase peristalsis, and then they'll have more frequent bowel movements. So you want to encourage exercise, dietary changes and modification, increase fluid intake, try to lose some weight, and let's see, what else? So, all right. But with a person like this, when they come in, you're going to always think of maybe this person can go to surgery. And not saying that they will, but you always want to anticipate. You always want to be proactive when you're nursing. You never really want to say, hey, you're thinking bad every time you go to work, because that's not really what you're doing. It's anticipating the worst. so you can be prepared for it. And that's how you should look at every day when you go in. When you see your patients, you're thinking of what's the worst thing that can happen to this person. And you prepare for it or anticipate it. Because you would hate for something bad to happen and you weren't prepared for anything. If that's making sure equipment's at the bedside, making sure you know which doctor is on call, or where certain things are on your unit that you may need for this particular patient. Another thing is that you're also going to monitor the signs of bleeding and check for codes. Let's see what else we got. Prepare for possible surgical intervention. A resection is done in 25% of the cases, so it's not that many. Because usually of a ruptured diverticulum, you gotta go to surgery for that. Antibodies that you may see on the unit would be ciprofloxacin, that's the cipro, that's the quinolone. You may see flagyl, metronidazole. You may see Bactrim. All of those are broad spectrum antibiotics, and that will decrease the bowel flora. So those you would see with issues with people with gut issues. You would anticipate looking for signs and symptoms of infection that y'all already talked about. Fever, chills, things like that. You're going to give them, we already talked about it, IV pain medicine, not PO, but they're in PO. So IV pain medicine and stool softeners. Somebody asked me, well, why wouldn't you give an enema or tell them about an enema or a laxative or something like that at discharge? Because they will cause a person to strain, which will increase pressure for the development of diverticulitis that can possibly turn into diverticulitis. So you want to tell them to hydrate, and you want to tell them to use stool softeners and exercise, like we talked about, and all those good things about eating. Where is it up there? No, it's not up there. Okay. All right. And also, if they have a fever, you want to make sure that you give them antipyretics, so like your Tylenol. Tylenol is basically for everybody. Alrighty, so nursing diagnosis. Person comes in with diverticulitis. I'm going to do this for you. So acute pain related to the inflammatory process. So what would you put on your nursing care plan related to pain?
Pain, reduce pain. Or nursing care plan? Yeah,
Okay, but what are your interventions that you're going to put underneath it?
Reduce pain.
Okay, by what?
Oh, by
administering
medication.
Okay. All right. So you're going to say, you're going to give analgesics as needed or as ordered to relieve pain. So how are you going to know that the person has pain? That's going to go into your nursing care plan. You're going to ask them, what's their pain rated at. All right. Other things that you can do also underneath, you can talk about position changes. So think about it. So a person comes in, they're probably going to be in a fetal position. If you have that person stretched out in a supine position, that's going to stretch all of the abdomen. That's going to cause pain. So you're going to have them in a semi-collar position. So you can talk about, putting the patient in a semi-collar position to reduce pain. And then if a person has an NG tube, you can talk about mouth care or care, some kind of care, to prevent, to increase comfort. All right, so a second one, risk for deficient fluid volume. What time is it? So when do I stop? What is 50 minutes? Is it now?
No.
It's not down yet? How many more minutes I have for 50 minutes?
40.
I have 20 more minutes?
Yes.
Oh, wow. So, so for risk for fluid volume deficit, related to what? Why would a person have fluid volume deficit with diverticulitis? Diarrhea, and then you got the institute because nausea and vomiting if it occurs with diarrhea. Yes, that was right. So, as a nurse in intervention, what would you do?
With the IV, administer.
That's right. I mean, yeah. Administer IV fluids as ordered. But what would you do before that? Simpler than that. I know.
Oh,
You want to make sure that what they're putting out, they're at least replacing. All right. So you want to make sure that you do their eyes and O's. Another way that you can see about volume deficit, if they can get up. The beds, now the beds are all fancy, so you can do a daily weight. See if that helps you weigh them daily. You're gonna vital signs, monitor vital signs. We talked about eyes and O's, and we talked about IV fluids. Reinforced teaching, so fiber. You're gonna, when you're teaching, let them know, main thing, especially if they're going home. They're gonna probably get pain medicine when they go home. Tell them pain medicine will cause constipation. All right, and to make sure that they have adequate hydration. Also, if they did not have perforation, they were in, you gave them antibiotics, fluids, and all this other kind of stuff, and they were sent home, with the diagnosis of diverticulitis, tell them about the signs and the symptoms. Pain returns, fever returns. If the pain was in the left lower quadrant and now it's everywhere, perforation, come right back on in. Okay, so and then we talked about food, the salads, the spinach, the greens. And what to avoid: strawberries, raspberries, anything that can get caught in those diverticulitis. All right, so here's a nice little video that says exactly what we just said. But I like to do. Kind of reinforce everything.
We are going
I
on
apologize.
Everybody is so
excited for this. If you don't know.
Diverticular disease
Diverticular
is a
disease
condition
is a
occurring
condition
when
occurring when
pouches
pouches
form toward the
form
end
toward the
of
end
the
of
large
the large
intestine.
intestine,
Your large
or large
intestine, also
intestine,
known as
also
your colon,
known as your colon,
the cecum,
includes
ascending
cecum,
colon,
ascending
transverse
colon,
colon,
transverse
descending
colon,
colon,
descending
sigmoid
colon,
colon,
sigmoid
rectum,
colon,
and anal
rectum,
canal.
and anal canal.
The wall of your colon has
The
four
wall of
main
your
layers:
colon has four
the
main layers:
mucosa,
the
the
mucosa,
submucosa,
the
a
submucosa,
muscular layer,
a muscular
and the
layer,
outer serosa.
and the outer serosa.
Blood vessels, called
Blood
vasa
vessels,
recta,
called
supply
vasa
blood
recta,
to your colon.
supply blood to your colon.
Although the cause is unknown,
Although the cause is unknown,
diverticulosis is associated with a
diverticulosis
low-fiber
is
diet,
associated with a low-fiber
constipation,
diet,
and frequent
constipation,
straining with bowel
and frequent
movements.
straining with bowel movements.
Constipation causes increased
Constipation
pressure
causes
inside your
increased
colon.
pressure inside your colon.
Increased pressure may cause the
Increased
mucosa
pressure
and
may cause the
submucosa
mucosa
to
and
herniate through a
submucosa
weakened
to
area of the
herniate
wall
through a
of your
weakened
colon
area of
and
the wall of
form
your
a
colon and
diverticulum.
form a diverticulum.
Diverticulosis occurs when you have these
Diverticulosis occurs when you
diverticula,
have
but
these
often no other
diverticula, but
symptoms.
often no other symptoms.
In contrast,
In
diverticulitis
contrast,
occurs when the
diverticulitis
diverticula
occurs
become
when the
inflamed.
diverticula become inflamed.
The usual symptoms of
The usual
diverticulitis
symptoms
are
of
lower
diverticulitis
left
are
abdominal pain,
lower left abdominal
fever,
pain,
constipation
fever,
or diarrhea,
constipation or
and decreased
diarrhea,
appetite.
and decreased appetite.
Diverticulitis may develop an
Diverticulitis
accumulation
may
of
develop
pus
an
called an
accumulation of
abscess.
pus called an abscess.
Excessive swelling and accumulation
Excessive
of pus
swelling and
may lead to the
accumulation of
formation
pus
of a
may lead to the
perforation,
formation of a
allowing pus and other
perforation,
material
allowing
to
pus and
escape
other
into your
material to
abdomen.
escape
This
into
is
your
a very
abdomen.
serious
This is a
condition and
very
requires
serious
immediate
condition
medical
and requires
attention.
immediate medical attention.
If you have a severe case
If
of
you have a
diverticulitis,
severe case
you
of
may need to have a
diverticulitis,
procedure
you may
to drain
need to
an
have a
abscess.
procedure
You
to
don't see
drain
that
an
often.
abscess.
That drainage. You will see
If the condition persists,
If the
you may
condition
require surgery
persists,
to
you may
remove the
require
affected
surgery
part of
to
your
remove the
colon.
affected part
During
of
your
your
procedure,
colon.
your
During
surgeon
your
will pass the
procedure,
remaining
your
end of your
surgeon will pass
colon
the
through
remaining
your
end of your
abdominal
colon
wall,
through your
creating an
abdominal
opening
wall,
called a
creating an
stoma.
opening called
After
a
your colon
stoma.
heals, it
After your
can be
colon
reattached
heals,
to your
it can
rectum.
be reattached to your rectum.
The main treatment for
The main
diverticulosis
treatment
is
for
increased consumption
diverticulosis
of
is
fiber-rich
increased
foods
consumption
to
of
soften and
fiber-rich
add
foods
bulk
to
to
soften
stools,
and add
which
bulk
helps
to
stimulate the
stools,
colon to
which helps
contract
stimulate
and
the colon
eliminate
to
them.
contract and eliminate them.
Other treatments for
Other
diverticulitis
treatments for
include a
diverticulitis
clear liquid
include
diet
a clear liquid
and
diet
oral antibiotics.
and oral antibiotics.
All right. So, where am I now? Okay. Why would you tell a person to avoid lifting, straining, and bending during this time when they have diverticulitis? They can pressure. It causes a pressure, which can cause rupture, perforation, because this is when the person actually has diverticulitis, so you want to make sure that they avoid anything that will increase the pressure in the colon that can cause perforation. Alrighty, since I finished that kind of early, I think early, alrighty, so we're starting on BPH, so benign prostatic hypertrophy hyperplasia. So BPH is the enlargement of the prostate gland. Normal process in aging. This gentleman will have BPH. He will. And I say that because you will. You live long enough, it's gonna happen. It's inevitable. Now there's only one, and we'll talk about that in a second, one group of people who probably will not develop it, and that's gonna come up in a second. So it begins around age 50 and exists in about 75% of men. Older than 70, you live to 100, you got it. Okay? BPH. So hypertrophy is the size of the cells. So the size of the cells have grown. Or hyperplasia means the amount of cells. So it's either the cells have grown or you got a whole bunch of them. But basically what happens is that it grows and it starts to press on this, compress this urethra, okay, and cause a bunch of problems. BPH does not cause cancer. So, of course, like anything, something's wrong, especially if somebody sees some bleeding. First they're going to think is, do I have cancer? You can't say yes or no. You can say, we'll wait till all the testing comes back and your provider will let you know the results. Okay. All right. So, so the prostate gland, like it grows, enlarges slowly as a man gets older. It extends up to the bladder, compressing the urethra.
says it's
Sorry
both
about
of
that.
them. Is it both or is it one of the, is it hypertrophy and hyperplasia or is it
It,
one
it,
of the
it could be one or the other. It could be a combination of both. The biggest take home with this is that it's the growth of the prostate is compressing that urethra, so you have an outlet problem. The urine cannot get out. So as it grows, like I said, the urinary the output is obstructed, causing urinary obstruction. A person will come in and, or y'all may be working in an office, or y'all become MPs, and somebody comes in, and as you're going through your assessment, you're asking, Mr. Jones, has your urinary stream changed? Has your stream changed? He may be honest, he may not, but if he hesitates, there's a good possibility that his stream has changed, and you go in and you start asking more questions, and with that, usually that's the first sign. If their stream changes, that's usually one of the initial signs of they start to develop BPH. As this grows, the urine goes up, it'll start a little pouch, and then if this totally is occluded, then the urine will start to expand into the renal pelvis, and it'll start to dilate the ureters and the kidneys, and so the patient will develop kidney damage. So that's why it's important that when we see these signs and we ask these questions, that we really jump on it quickly to prevent. We can prevent a lot of things from happening if we just ask a couple of questions. So as this, as the prostate enlarges, the urine goes up, urine stasis can occur. So with urinary stasis, infection bacteria can develop, causing urinary tract system symptoms. And I talked about the dilatation of the ureters and the kidneys. And this dilatation, that accumulation of the urine, is called hydronephrosis. And if this is totally occluded, I think he's coming in. I mean, he's coming in because he's gonna have pain. But like I said, having BPH doesn't increase the man's chance of developing cancer, but it can cause a whole bunch of other problems. UTIs that's not treated. UTI can kill you. Somebody died recently, some lady, I don't know, some actress or something. But and she was fairly young. So untreated UTIs can cause death, can cause sepsis, you can die. And bladder and kidney damage. Okay. Let's see. We'll talk about that. So cause unknown. They don't know. They just say it's a normal part of aging. Some men think it's because of certain sexual practices. There's no literature that substantiates that. It just happens. They do say that some men, they're finding some kind of correlation between high-fat diet, meat consumption, and certain ethnic backgrounds and excessive alcohol intake. They're saying that could possibly have something to do with it. They're talking about smoking could possibly have something to do with it. But there's really no known prevention of BPH. Like I said, if a man lives long enough, then he will develop it. But there is a certain population that everyone will come into contact with that probably may not develop BPH, and that would be your transgender men. And that is because Prostar, which is used, and we'll talk about it in a little bit, so a transgender male may, take maybe 5 milligrams of Prostar. Men also take Prostar for hair loss, but that's at a lower dosage. so that's like 0.5. That's not going to stop it from developing BPH. But 5 milligrams of Prostar, taking it in your 20s, will reduce or probably, totally negate the chances of you developing BPH. But it's new, so that's what everybody's assuming, and that's what it kind of goes with, because it reduces the development of DHT, which I don't have to know about, but more or less Prostar is used to shrink the prostate. So if you're taking it, you're keeping the prostate, you're preventing it from, growing from the beginning. So that's the theory. We'll find out as time goes on. But I just want to say that. So if you see somebody who has finasteride on their, on their MAR, it's one of two things. And so I just want to do that. So person comes in, BPH, they're going to have symptoms of a lower urinary tract infection. Or symptoms, lower urinary symptoms. So they're going to have difficulty starting the flow, even if they're straining. If they're straining, can't come out. They may have a weak stream. They may have multiple interruptions, like they kind of go stop, go stop, go stop. And then they may say, I'm finished, and then they're still dribbling. So these things that you will see with BPH, they may also complain of frequency, feeling that they just can't empty their bladder. They may have nocturia, they're waking up all night, dysuria difficulty. Urgency, I gotta go, I can't make it to the restroom. They may be even having some urinary incontinence, hesitancy, burning. We talked about weak stream, we talked about dribbling, and they finished, and they're still dribbling. So what are we doing? We're doing a UA. We're checking for any kind of urinary tract symptoms. We may even do a urinary culture, because there are certain medicines that you will give in the beginning. Men will typically give ciprofloxacin, but we'll still do a culture because sometimes people, the bacteria is resistant to it. So a culture just makes sure that the antibiotic therapy that a patient has been given by the provider is actually going to treat the infection. Because what can happen, a person will feel better, because antibiotics will work to a certain degree, but it won't eradicate it. And once they finish the antibiotics, it comes back and probably worse than it was before. So if you have somebody that keeps coming in with the same kind of symptoms, definitely they're going to get culture. You're going to start noticing some urinary retention, because they're just not going to go out. What's another way that you can check for urinary retention? True, on assessment. Somebody said it. Bladder scan. So, somebody's in, you tell them the void, so it's like a pool void residual. You have somebody come in, they urinate in the urinal, and then you do the bladder scan. Sometimes you may see orders that say, hey, if it's, more than 200, 300 milliliters in the bladder, put a catheter in. You're checking with the UA, should do it as well. Hematuria, we don't check for that. The provider's going to do a digital rectal exam to feel for the prostate to see how large it is, and we'll talk about some diagnostic tests in a second. If BPH is left untreated, so the prostate's growing, and boom, like we talked about, it completely obstructs the urethra. A person will have bladder outlet obstruction. And we kind of talked about this. So they'll have urinary retention, will develop infections, UTIs. They may even develop bladder stones. We talked about the hydronephrosis with all of the accumulation of urine backing up, dilating the ureters and the kidneys, and then causing kidney damage. Remember what you said? No. So, diagnostic tests. Of course, assessment. Gotta do an assessment. That's number one. assessment, ask the patient's history, you do your assessment, like the young lady said, you're looking for bladder distension, you're taking some vital signs, you're looking for fever, you're asking them about chills, you're going to ask all those symptoms, all those things about, frequency, urgency, dysuria, nocturia, ask all of those questions. You're going to do a UA to look for, like we talked about, white blood cells, hematuria, we talked about the urine culture. Like I said, the provider will do the rectal exam, not us. Another thing is not on here that they may order is called a PSA. A PSA. Oh boy. Prostate specific. Yeah. So PSA, and what a PSA does is that if a provider is not sure if it's cancer or BPH, they will do a PSA. And that will let them know, what is, because, they have to rule it out. So usually if a PSA is greater than 0.4, if it's greater than 4, then they will send that patient to a urologist to do a biopsy to make sure. Okay. Because we never want to think that it's one thing and it's really another. So, but it's a possibility that your PSA may be elevated depending on how bad the infection is. But if you're asking questions early, we can diagnose this and start treating a lot earlier before before any kind of complications can develop. But a PSA, you would expect to see that on your doctor's order. Let's see. Serum creatinine. Okay, so a BUN and a serum creatinine, that's looking at kidney function. CBC is white blood cell count. The person has been having, you can have microscopic hematuria or hematuria. They may see that. They may be checking a hematocrit, see if there is any significant blood loss. The serum creatinine, you're on the floor and you're looking at their labs every morning, and just say their creatinine, 2 days ago was 0.9. This morning they draw the labs and the serum creatinine is like 2.5. And I think the high normal is about 1.2. Please know y'all labs, not just for me, for everybody. It's and so that prompts a call, because you need to call the provider and be like, okay, look, this person has a bump in their creatinine, it's going up. Y'all are doing y'all eyes and nose anyway, so y'all should know, is it because of dehydration or what? Because if they have a low urine output, it could be dehydration, they need some fluids, or it could be because of this. But if you see a bump, that's letting you know that there is some kind of kidney damage going on. You gotta let them know so they can figure out what they need. We talked about phase 4 review, biopsy. All right, so let's say we're working in the ER. Man comes in, he's like all over the place. He's having pain. Says I haven't urinated in 12 hours. And I'm hurting. First thing that you're gonna do, once you do your assessment, you ask the questions, he hasn't urinated, boom, even you can run out and tell the provider if you want, but the first thing that you're gonna do is find and indwelt the catheter. You're gonna catheterize this man. So have any of y'all put in a catheter in a man? Yeah. Okay. A lot easier than a female. So but what you'll find with the person with BPH is that you're taking that, those catheters, they just flop all over the place. And as you're going in and advancing it, It's like you hit a wall. Like, I cannot advance this catheter. You may even see it kind of collecting, like the shaft, and you'll see this ring, and it's like. So then what you do, you go out and you tell the provider, hey, this catheter is not going in. So they'll say, oh, go get a Coude catheter, COUDE. They're various sizes. They're kind of like a stiff, I wish I brought it, I apologize. They're a stiff catheter. Usually they could be red. I guess they can come in yellow, but usually we say red rubber cath or Coude cath. And they're a little stiffer than your Foley or indwelling catheters. Because what you're trying to do is you're trying to give this man some relief. And you're going to take that catheter and you're going to push it through. You may hear some crunching. I'm sorry. But you may hear some crunching, but you have to try to get that through. You may have to try a smaller size to see if you can get it through. And after 2 attempts, you call it neurology. We've done what we can do. We cannot. This man needs some relief. Someone asked, I don't know, I think it was last semester about, when you decompress a bladder quickly, a person can develop hypotension. Yes, they can. You can have hypotension right now, going to the restroom, urinating. You can go and you can have a vagal basal episode where you will feel like you're faint and passing out right now if you're going to try to have a bowel movement. Okay? And from what I know, all of y'all are just fine. But if you have a man that's coming in uncomfortable all over the bed, he's in the bed, decompressing his bladder, not saying it is more important than hypotension, but he's already in the bed, he's already hooked up, he already has fluids, he already has blood pressure, you're going to catheterize this man. Okay? So, you may see orders for antibiotics. The antibiotics are after they've done the urinalysis and know that there is an actual infection going on. And some people, I'm not really going to ask you about a suprapubic cystotomy, but you may see somebody who has, in the suprapubic area, they'll have the catheter inserted in the suprapubic area leading to the bladder to drain it. So this is a medium. Okay. So let's just say, let's scrap this. You're seeing patients in the doctor's office, a man comes in and you're asking questions. He's saying that his stream is fine. It is a little weak, but I'm good. So what you'll do and what the provider will do is just watch him. That's all. You just watch him. You don't do anything to this man. If it has not affected his quality of life, you leave him alone. Okay? He's not having any frequent urinary tract symptoms, leave him alone. But as things start to progress, you start off, of course, less invasive. You're going to do conservative stuff. So you may see an order for Proscar, like we talked about. Proscar is used to help shrink the prostate. Hopefully with shrinking the prostate, it would give them a little sliver of urethra so they can have some urinary output. You may also see an order for Flomax or Tamsulosin. Flomax. What that does is that it relaxes the muscles, yeah. Relaxes the muscles of the bladder, the urinary tract system. To hopefully they're thinking if it's tense or tight, it will allow urine to flow. Usually they'll probably start off with Flomax, and they may go to Prostar, but it's always good to know both. We're not gonna be that specific. Which one will we use first? Yeah, so so if you are relaxing the bladder, urethra, all that muscle tissue, you should see So if you use Proscar, you use Flomax, and they return after so long, your first question should be, Mr. Jones, we started you on this, we started you on that. Have you noticed an increase in your urinary output? Yes or no? Okay. So, you always gotta ask. If you give it any kind of medicine that's supposed to help dogs or your pain, whatever, you go back and you reassess. You reassess for the effectiveness. That's what it means. Let's see what else I can say. So you've used these stuff, you use Proscar, you use Flomax, and they're not working anymore. He's having recurrent infections. He's having gross hematuria. Now you're starting to see your BUN, your creatinine is starting to increase. It's letting you know, hey, there's some kind of bladder and kidney damage. Now, or in addition, just say his lifestyle has changed. So now it's like, what can we do? TURP, transurethral resection of the prostate. You'll see this more than anything. So, with this procedure, the person is anesthetized. They'll use a cystoscope or a resectoscope. They will insert it into the urethra and down to the prostate gland. And as you can see, it's exactly what it's doing. It's chipping off a piece of the prostate, a piece at a time. It'll also have some kind of, cauterizer to kind of reduce some of the bleeding while it's doing it. It may also irrigate as well to while it's chipping, it's trying to, can't think of a better word than, I guess, remove those chips. It irrigates it and it sucks it back out to remove those chips. It's not completely removed, and it can grow back. It can grow back. So, once this is over, they will put a catheter in the patient, and put fill the balloon up 30 to 60 milliliters or 60 milliliters of fluid. And what that does is that when you put that catheter in, it's overinflated to try to, I guess, like, what do you call it, tamponize, to try to put some pressure against the area to try to reduce the amount of bleeding after. It may stay in place for about 3 to 5 days to drain the bladder, and then a person you'll probably see them on continuous bladder irrigation. So they'll have a 3-way catheter. One will have the fluid going into the bladder, another one, the bulb, inflating it, and then once it goes in, it should come out into your drainage bag. Now, your PCT can empty your bag. They cannot mess with these irrigation fluids at all, okay? But they can empty the bag. And technically, while you're going in there, reassessing the patient every 1 to 2 hours, you're checking to see what this drainage looks like. If this drainage in the bag, like so you just say you empty it, if the drainage in the bag is like, gross hematuria, lots of clots, you have to increase this. Because what's happening is that if this is clotting too quickly, you want to increase the fluids. You want to increase the fluids to allow this drainage to be pink, to let you know that you are irrigating all of those chips that may be left in there, all of the clots, because what's going to happen if a clot gets stuck in the urethra? Yeah, that's right. You're back where you started from. So that's why that's important. Okay. And then you also want to always make sure that this is flowing. You walk into the room and just say the person has come back from a procedure. If you see that catheter all kinked and, all, I don't know, all in the bed, you got to bring it down to allow that flowing. Because if it doesn't flow, all of this fluid that's accumulating is going to back up and cause problems, okay? It's just the little things that, we can do that can provide comfort and for our patients and to prevent any kind of adverse problems. So, okay. All right. So we're talking about irrigating. We're going coming in and coming out. So everything in that bag needs to come out. So it's important for us to empty the bag, because if over your shift, depending on how fast you have the irrigating, a person got in 1,000 liters of fluid. But when it's time for that output and you only have 500, where the other 500 go? That's a problem. And what will happen is that there's something called TERP syndrome. Because what happens is that the body starts to absorb this fluid. Okay? And with the absorption of that fluid, that person will develop fluid volume excess. So the person will have hyponatremia, too much fluid. They'll have a decreased hematocrit, too much fluid. They'll have hypertension, too much fluid. They'll have bradycardia, too much fluid. The heart is not going to be able to pump all of that fluid. They're going to have nausea, confusion, so mental status change. Anybody with a mental status change, you got to call somebody, because something is wrong. And that question can be in anybody's lecture, in anybody's test question. Mental status change is number one. If somebody has a mental status, I understand you're talking about airway, breathing, and circulation. I get it. But a mental status change is letting you know something is wrong with airway, breathing, and circulation. Huh? Oh, something wrong. Yeah, something's definitely wrong. And then, so you're assessing your patient. You're looking at the I's and O's. You may lower that, because if you notice that 1,000 should have come in, but only 500 came out, you may slow that down, because in your mind it's like maybe where is it going to go? They reabsorbed it. So in your call to your provider, you're telling them, Mr. Jones, mental status change. This is his irrigation. This is his output. This is his assessment. Because you got to vital signs, everything. You got to give them everything you call so they can make their decision on what orders they're about to give you for this patient. Let's see. And if it's not, and if you let it wait, if you let this wait, this person can develop dysrhythmias or seizures. Okay, so hyponatremia can cause seizures and mental status. So, let's see what else I can say. Okay, so if a patient, all right, and we kind of talked about this a little bit. So main complications after a TERP would be, clots, and that's why the irrigation is so important. Infection, because they've been chipping away all of them, chips, and cut off some of that tissue. Bladder spasms, you're going to have some discomfort. So you're going to tell them prior to, unless it's an emergency, prior to stop all NSAIDs, because NSAIDs increase the risk of bleeding. Let's see.
So does has it enlarged your apartment or is it still small?
Well, from what they say, it's kind of like it's walnut shaped. You can feel it, so it's probably enough for them to be able to cut it off. So it's got to have some firmness to it for them to be able to. Let's see. Oh, this is a bladder irrigation setup. We can pass that. Y'all can watch that. Unless y'all want to watch it. They said no. They said no. Whoever wants to watch it, we can watch it later. But I'm going to show you the other video. All right. Let's see. What are some questions somebody asked me? Talk about that.
I have a question.
Yeah.
So the CBI causes them to have spasms. So the CBI will cause them to have spasms.
Or they could just have spasms from the procedure itself.
Oh, also, I thought. So can this be secondary to like prostatitis or is it like a primary? Right. But can they cause it?
Well, I mean, it depends. If you have prostatitis and your prostate has enlarged due to inflammation and swelling, and it's large enough to cause an obstruction for a long enough period of time, yeah. But that would be left untreated, and somebody with prostatitis, inflammatory, they're going to have pain. They're going to treat that, so it may not even develop to this. But in theory, left untreated, it's a possibility.
Or can this cause prostatitis?
Yeah. You know, I've never seen that correlation. I've never seen the correlation. I can look it up, but I've never seen that correlation.
Well, I'm asking because I have a friend that been suffering with prostatitis for a long time, and he's older, so I'm like, should he be watching out?
Well, I mean, the thing is that if his stream never changes, then this wouldn't be an issue. See, this deals with the compression of the urethra itself. Okay? So if it never compresses it to a point to where it's backing up,
then it's not.
You won't have these.
Okay.
Let's see. Okay. All right. So these up here are not for you to remember. Okay. I'll let y'all know that. It's just that these are surgeries that y'all may see. I am going to point out a thing or two, but it's not that you have to. It's not that you have to. It's not that you have to know it. It's just that it's okay. So, what can I say about this? Okay, so with a suprapubic prostatectomy, if you work on a floor that has these surgeries, this is something that you'll know. If you never work on a surgery where there's a urologist that's performing surgery every day, you'll probably not even think about anything like this. But this is why I'll put it up there. Suprapubic prostatectomy. You're on the floor, you know that they made an incision in the bladder. So it is a possibility that you will see urine on your dressing table. And then also you want to make sure that, if urine is on the dressing until it completely heals, that you're constantly changing that dressing because what? Urine is what? Acidic, and what it's going to do is going to tear up the skin. All right? Let's see. And also, you always, when you're assessing a wound, with this one, of course, talk about urine. You want to look for purulent drainage, any signs and symptoms of infection. All right. You want to definitely report purulent drainage of any kind to the surgeon for any incision. Okay, this one. Now we're treating BPH, right? But look, this the lower abdominal area. Are you supposed to urine? No, the bladder is not into it. If you see urine, you gotta call somebody because y'all nicked the bladder. And the only reason why I bring this up is because wherever you're working, you have to know what they're doing and what it involves because you are the eyes and the ears of the patient. And if you know that I shouldn't be seeing anything yellow on his drainage, one, is it purulent drainage? And if it doesn't look purulent, does it smell like urine? And if it's urine, we got a problem. Okay? And that's why I put these up, because you really have to know what procedure your patient is going through and what to look for. Like I said earlier, you have to anticipate everything that you may encounter in that day with your patient. Did I tell you all that? Okay. All right. So what's the big thing about this one? It's just another surgery, perineal prostatectomy that y'all may see. Just, anything with prostatectomy, they've done something, they've taken it all out, they've done something. So, I just like to say that there are multiple surgeries for that. All right, so treatments. We talked about Prostar, and how it's supposed to shrink the prostate. We talked about Flomax, which would relax the smooth muscles, hopefully increasing the urination. Transcystoscopic urethroplasty, that's just like putting a balloon. So they go in, you know how we talk, you hear about, balloons in the heart, same kind of thing. They're going in with the balloon to open up the urethra opening that will, push the prostate long enough for something to give them some kind of relief. Transurethral incision at the bladder. You may hear something where they may do transurethral microwave therapy where they'll put an electrode through the urethra by the prostate and try to burn off some of that tissue in hopes that it will cause it to shrink to allow urine to pass through the urethra. You may even hear of them implanting an intraurethral stent, which will kind of just go in there and try to keep that area open to allow urine to go through. But the only thing about these the stents is that they're only good for 4 to 6 weeks. So, the man is going in every 4 to 6 weeks to get a stent placed. Not really quite sure of how that feels, but I know that's but some people are not surgical candidates, so that's why they have other options for it. All right. So let's how many minutes we got? We're gonna watch this video and then we're gonna finish it up. Ah, you have 11. I thought you got at 10:30.
12.
Oh, I'm talking at 12. Oh, Brad. Okay, well, watch the video later on. It's a nice little video. All right. Okay, so we said about this. On admission, you're looking at their age, you wait for possible infections, you want to reduce their anxiety because of course the first thing they're going to think is that they have cancer. You want to encourage fluids, unless contraindicated. You want to make sure you monitor eyes and nose. We talked about that. We talked about the drains of the NDO catheter. About maintaining the gravity of the indwelling catheter, making sure that if there are getting that continuous bladder irrigation, no need for clots, making sure that it's not obstructive, making sure that, you're addressing change. One thing that y'all may already know about is that usually the first dressing is always changed by the surgeon who performed the procedure. 99% of the time. But there are those instances where, and y'all hear this in periop, where if something's going on and you have to look at that wound, you won't have to call them because I'm about to open up this dressing because something's wrong. Especially if somebody says, I just feel like everything just came loose. Oh, you gotta look at that. Because you may have, if it's an abdominal wound, those abdominal organs and all those contents may be sitting on top of their abdomen. You gotta make sure that they're moist and all this kind of stuff. They gotta get back to surgery. But you definitely, you want to make sure you change the dressing if they become wet. If they have any feces on them, you want to make sure that you change them. Of course, monocyte, hematuria is expected. Frank bleeding is not. So your patient's going home, when a person is going home, every day should be better than the last, right? So if a person, they should have some hematuria, which should decrease. But if they're calling you 3 to 5 days after discharge, now they've already been in the hospital 3 to 5 days, now it's 3 to 5 days after they've been the surgery, after they've been discharged. If they're calling you saying my stream has changed, you need to tell them to come back in because they're obstructed again, and they got to figure out why. They may have to come in, you may have to put in the catheter and send them back home. Or if they say, I'm bleeding, like I got lots of please come. Go to the emergency room and come on in. Encourage to avoid straining. Encourage fluids, stool softeners because you don't want them to strain. Let's see what else. The video says this. You want to educate your male patients with BPH to try to avoid antihistamines and decongestants because it will make it more difficult for them to urinate. Tell them to not drink fluids at bedtime because they have to go, they gotta go, and you want to try to reduce the incidence of them getting up onto the bathroom, falling, and breaking a hip. Avoid any kind of alcohol. You want to educate on avoiding alcohol and caffeine because it increases urination. And tell them to empty their bladder when they pull. Those are some education things. Okay, so these are just some, retention is blocked. UCI is usually because of urinary stasis. Bladder stones because of mineral deposits. Bladder stones can also obstruct the urethra, and you can develop bladder damage and kidney damage because of that stretching due to the accumulation of fluid. Please don't forget there is a discussion board. Y'all can email, discussion board, all those wonderful things. Anybody have any questions? And I do have some questions on Canvas, like practice questions, just kind of get your mind back into the mood of Rebecca. Any questions? No? See y'all later.